Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the Quorum Podcast. I am with Dr. Winston DeMello. Dr. Winston DeMello will be talking about the shocking news on lactate. Winston, you've chosen a catchy title for this week, so can you explain your choice?
Well, first of all, thank you for asking me to talk on this podcast. It came about by a realization that most people feel that lactate is a metabolic waste product under hypoxic conditions with multiple harmful effects associated with low oxygen conditions. But unfortunately, or fortunately, depending on which way you look at it, there is more to lactate than shock and sepsis. And the discoveries of the lactate shuttle about 20 years ago, and its role in as a signaler molecule, and in various disease processes, like, for example, pulmonary hypertension, pulmonary fibrosis, heart failure, atherosclerosis, polycystic kidneys are the non-cancerous ones. And people may be surprised that it's also involved in cancer and tumor formation. It was in the 1920s that Otto Warburg noticed that tumors consume more glucose than their surrounding normal tissue. And he then proposed the phenomenon of aerobic glycolysis. So despite there being a good oxygen delivery, glucose can still be fermented to produce lactate instead of carbon dioxide, even in the presence of oxygen. And this is known as the Warburg effect. So all in all, lactate is not just a byproduct. It's a critical chemical in the metabolism, in human health, and in disease. And I hope over the next few minutes, we will discuss these.
So given the possibility of measuring lactate, we have point-of-care testings at paramedic as well as docs. Can we discuss some aspects of the lactate metabolism and how lactate is produced?
Sure. In terms of lactate metabolism, in the presence of oxygen, it occurs in the mitochondria, which is the powerhouse for producing energy. And glycogen stores will be broken down to glucose and by glycolysis into pyruvate. And pyruvate is really important because in severe exercise, pyruvate will be converted to lactate. That's an important point that we'll discuss later. But if there was sufficient oxygen, then pyruvate is then converted to acetyl-CoA, and that feeds into the Krebs cycles and produces 34 molecules of ATP. So that is how energy is formed. Acetyl-CoA can also go into lipogenesis, so it can be stored as fat. Now, the beauty about lactate is that lactate formation is converted via the Cori cycle. So that's a completely different cycle from the Krebs cycle. And that was named after husband and wife, Carl and Gertie Cori, who in 1929 discovered it. So let's take somebody doing severe exercise, and you obviously don't have enough oxygen delivery to cope with the exercise energy requirements. So the lactate produced is then taken by the bloodstream to the liver, where it's now reconverted to pyruvate. So do you see what I mean? The relationship with pyruvate and lactate is critical because basically when you finish your heavy exercise, your lactate is converted mainly in the liver, but also to a certain extent in muscle and in kidney. So about 70% liver, 20% kidney, 10% muscle. So you can see that if you have an oxygen debt, you've got to pay that debt back. So the Cori cycle is basically paying the debt back. And that's why you feel quite tired and fatigued after a severe amount of exercise. And it takes, in a healthy person, about an hour to recover the oxygen debt. So lactate and pyruvate are intimately involved in this process. So I want our listeners to appreciate that lactate is not just produced in anaerobic conditions. It can also be produced in aerobic conditions like in tumor formation.
So we focus on lactate. It never dawned on me to think, where does it go and how does it go back? It's interesting that there is a relationship between pyruvate and lactate, and they feed on each other. So listen, there are two classifications for high lactase results. Can you take us through the first simpler classification?
The simplest one is the type A and type B classification. Type A is when there is a hypoxic problem, either due to impaired oxygen delivery, and type B, impaired oxygen utilization. So if you go back to type A, impaired oxygen delivery, this will occur in hypotension, hypovolemia, trauma, septic shock, severe anemia, cardiac arrest, regional ischemia, compartment syndrome. All known, most medics will be familiar with that. The other way in which you get a type A, which is impaired oxygen delivery, is when the oxygen demand is increased. So as in stress, pain, fever, exercise, seizures, shivering, the use of beta agonist, increased work of breathing, somebody who's in respiratory failure, localized soft tissue infection, mesenteric ischemia, etc. So that's all to do with oxygen delivery. Type B is impaired oxygen utilization. Now, this have three main sort of categories. One is drugs, which is quite surprising, but quite commonly used: propofol, biguanides like metformin, HIV antiretrovirals, acetaminophen, that's paracetamol, alcohol, sodium nitroprusside, which we use occasionally in cardiovascular emergencies. And then there is the impaired clear clearance, because you know that the lactate is metabolized by the liver and kidney. So in systemic renal failure, liver failure, you're going to get a high levels of lactate. But it can also occur when you get these rare genetic abnormalities of the mitochondria. And then finally, inborn errors of metabolism, usually around the vitamin B1, B2, beriberi disease type of diseases. So that's the broad picture. Type A, impaired oxygen delivery. Type B, impaired oxygen utilization. There is a third category, type D, where there is bacterial overgrowth. This occurs when surgeons operate and you've got a short bowel, and it encourages bacterial overgrowth. So that is the sort of overall view. One is hypoxic and the other one is non-hypoxic.
And that second one is a Cohen and Woods, or is that the next point?
Cohen and Woods is another example of classification, and this one takes it a little bit in a more logical order. The first one categorizes A, where there is reduction in impaired oxygen delivery, which we've already discussed. B1 is a disease process like liver failure, renal failure, stress, shock, cancer, paracetamol overdose. B2 is drugs and toxins, which we've talked about, like metformins, the retrovirals, beta agonists. And the final one is B3, inborn errors. So it depends on which one you prefer, but they are almost the same thing. So what I would like our listeners to take on board is that when you do a lactate on somebody, it isn't just sepsis, it isn't just shock, it isn't just a simple error where you're getting a smoky fire as opposed to a clean fire. So lactate is not just a smoky fire where it's inefficiently produced. Lactate is a very important compound in the body's physiology, let alone pathology. So that's the main sort of drive of taking up this subject up as a podcast.
I see this as much broader than what we see at the paramedic level. Lactate is something that we look at above 2, and if it's above 2, we know that there's some sort of oxygen delivery problem. But I didn't realize it went in a lot different pathways from that.
Yeah.
So looking at this as a clinical presentation, what symptoms will the patient present with?
For most of us, when we're dealing with sepsis or we're dealing with shock, we know the lactate levels are going to be a good trend indicators as to how well treatment is going or how badly the disease is progressing. But somebody presenting with a high lactate levels may have very non-specific symptoms like abdominal discomfort, nausea, loss of appetite, diarrhea, fast, rapid breathing, weakness, fatigue, just very vague things. So what I want our listeners to appreciate is that if you get somebody with very non-specific, nothing to suggest sepsis, nothing to suggest shock, but they have a higher lactate level than normal, think about the other causes of high lactate levels other than the classical ones where there is just impaired oxygen delivery. It could be impaired oxygen utilization or due to renal and liver dysfunction or drugs. That's basically it.
I've heard you say in lecture many, many times that the clinical presentation and patient history is more important than numbers you get from a point of care testing. And this sounds like one of those points.
Yeah, definitely.
So what are the practical aspects of blood sampling for lactate measurement?
Well, this may come as a surprise to our listeners. The arterial sample is the best one. But most of us take venous samples, and it is important that the sample be taken within 2 minutes of applying the tourniquet. And then it must be put into the machine within 15 minutes. If not, there's going to be a problem. And then the suggestion is that you repeat the test within 30 minutes of the first sample. If there is a delay, then they suggest putting the blood sample into a fluoride oxalate bottle with no ice. So those are the practical aspects. And from a body point of view, you're going to get different lactate levels from different venous samples. So remember to take the same site if you want to see a proper trend. Otherwise, you might get errors. Say, for example, if you've got an ischemic upper limb and you take samples from that limb, that may be high. But on the contralateral limb, which is not ischemic, may be low. So lactate is a measure of the blood and flowing from the tissues from which that venous drainage is coming from. That's why arterial samples are better.
That's not something I thought about. If you have a burn casualty or a crush casualty and you're taking lactate, I always thought lactate is lactate regardless of where you pull it from. But it makes sense. So how close the lactate sample is taken to the injury. So external jugular will be probably the best place for a lactate?
Right atrial would probably be the best because you've got then the mix of the inferior and superior vena cava. So you've got a proper mix of the samples.
So we always focus on 2. We're just as beat into our heads as paramedics. Lactate of 2 or higher, and there's a big problem. Can you go into more detail with that? How high of a lactate should be a warning sign, and how do we manage that?
Okay, I mean, the normal values are between 0.5 to 2.2 millimoles per liter, or in old-fashioned numbers, 4.5 to 19.8 milligrams per deciliter. So those are the normal values. Anything above 2 has got a high lactate level, and it may be protective, as, for example, in a response to shock. But unfortunately, if it's not recognized, that increases the risk of morbidity and mortality. So it is a marker of emerging or actual critical illness, which increases morbidity and mortality. And therefore, what we advise is measure serum lactate in all suspected or active serious infections, because it will give you a trend analysis on whether what the disease trajectory is going to be like. And certainly if, as it occurs in all stages of shock, if it's above 2, the recommendation to escalate care, and if it's above 4, it needs a rapid response. So that gives you your cutoff points. So whilst in the various stages of shock, maintaining blood pressure may be soothing and calming news to the clinician, these can be deceptive, reassuring vital signs, and therefore the importance of lactate as an indicator of something not going right is important. And we know that you get a higher lactate in sepsis, any forms of shock, anything that increases catecholamine response, like in hypothermia seizures, and the drugs which we've mentioned. But don't forget common drugs like adrenaline, salbutamol, metformin, all can cause high lactate levels. The measure must be taken in the context of the history and what the likely cause is. It shouldn't just be used just as a sole indicator of sepsis or shock.
So the history of the patient. Yeah, it's all about the history of the patient, and the rest of this can just verify what you're already thinking.
Yeah.
Brilliant. That's a lot more than I knew about lactate, and I appreciate the deep dive into lactate. You have any final thoughts or suggestions for the austere paramedic out there?
I think just take a good history. Don't just think of shock and sepsis or infection. Think about other reasons. Just go back to your books, look at the Krebs cycle, look at the Corey cycle, because these 2 cycles will explain the pivotal importance of pyruvate and lactate, because pyruvate is part of the aerobic metabolism in the Krebs cycle. And the lactate is like, if you like, a side journey, a smoky fuel, as we used to think it was in the past. But in fact, the Cori cycle converts the lactate back into pyruvate, therefore paying the oxygen debt from when somebody goes from an aerobic to an anaerobic metabolism. The second point is treat the cause. If it's sepsis, treat the sepsis. If it's hypovolemia, treat the hypovolemia. So correcting the process that's causing it is important. And only in very, very low pHs would sodium bicarbonate be used, because remember, sodium bicarbonate doesn't affect intracellular acidosis. So you've got to use it only in extremis. And then the second one is just remember the rare cases where it may be due to an inborn error metabolism of a mitochondrial defect. Then obviously you'll need to take a top cover and use a vitamin-based protocol. For example, I mentioned vitamin B, B1, niacin, and carnitine. These are really small print stuff. But generally speaking, lactate is not smoky energy formation. It's actually a compound that is working physiologically, occurs in signaling, and can affect lots of diseases that we've mentioned, including tumor formation. So it's not just a byproduct of a smoky metabolism or anaerobic metabolism. And if you bear that in mind, then the rest becomes simple, because the history you should pick up the other possibilities where the oxygen utilization is not working or there's drugs on board. So don't just regard lactate as just a pure indicator of shock and sepsis or infection, but there's a little bit more information for that. And when I read up on the subject for this podcast, I was just stunned by the almost road to Damascus conversion when you realize, hang on, it's not just smoky metabolism. There's a lot more lactate than meets the eye. And I hope those listening today will have got a better understanding of where lactate in the body is actually not pathological, but is physiological. But it's only when it gets to the higher levels, beyond 2 and then certainly beyond 4, there's something going wrong. Try and identify the cause. Fortunately for most of the medics, it'll be sepsis and shock. That's understandable. But just remember, it's a little bit more complicated than that. And you just need to keep an open mind by taking a good history and trying to work out what's going on in the body.
Thank you, Winston. This will definitely make better medics out there with a deeper understanding of lactate.
Good.
Thanks for sharing, and we'll see you again next month on the next podcast.
Okay, thank you very much indeed.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corom, Corum.org.